Okay, it's now exactly 18 hours, 6 p.m. South African time, and it means it's time on a Thursday. It means only one thing. It means the time again for our clinic sponsored webinars. The webinars are sponsored by Clinix Health Group, and we are proud to be able to provide this service as clinics to practitioners in the healthcare sphere within South Africa. We've been doing this for now 5 years now, 4 years. And I think for as long as people log in, we will continue to do so. We are waiting for those who are in the lobby to be assisted in joining. And there are still a few, but we've got, I think, 170 at the moment who are logged in. Some are still being admitted as we speak for tonight's call. But I'm Enes Kinoshi, Dr. Enes Kinoshi, associated with Clinix Health Group. And we are here today to do yet another one of our weekly Thursday evenings webinar, same time every time. We welcome especially the new ones. We always have new ones. We always have loyal attendees, I think, who have been with us for years, and for that we are very thankful. But we also always have new ones. So bear with me as we go through the house rules, as we always do. It takes 1 minute. These webinars are offered free of charge, sponsored by Clinix Health Group. So you won't be charged anything, but you have to join yourself. In other words, you need to register, and in registration, Cholakele, please mute everyone. For now, people will mute everyone so that the presenter can present uninterrupted until the end of the presentation. And then at the end of the presentation, we will allow participants to raise their electronic hands, and they can make their comments or ask questions orally as they wish. During the presentation, you'll also be able to put your comments or questions in the chat box that is provided for you in the system, and the presenter will attend to them during the questions and answer period. Once you've registered, you will automatically, if you are an HPCSA member, receive your CPD points. They will be emailed by HPCSA directly to you within 2 to 3 weeks. At times it takes 4 weeks, but I think they are faster now, 2 to 3 weeks. If you have not received your CPD points or by email from HPCSA directly, after attending any of the webinars, you can always contact us on webinars@clinix.co.za. Webinars@clinix.co.za. And if you have received the Zoom link secondhand, maybe somebody sent it to you and you managed to join us, you are quite welcome. The only thing is that if you do it that way, then you won't get CPD points because you haven't registered yourself. So you can still register if you, provided you do it today, the day of the webinar, or if, of course, you could have done it before as well, but not after. And then you can then receive your CPD points. Please don't use, like people continue to do, despite being warned. Please don't use your PHF practice number. It won't work. So it should be your registration with your body of registration. If it's a nursing council, South African Nursing Council, Pharmacy Council, use that number as well. Our team will handle it and ensure that you receive your CPD points one way or the other. I think I'm going to hand over to our speaker today, I can assure you, I've discussed it with our speaker today that we will release you in time to see Bafana. I think you're all ready. The match is much later at 21 hours, fortunately, so we won't interfere with it. It would be done by then. I learn the the opening ceremony in Mexico. There'll be 3 opening ceremonies, one in the US, one in Canada, with their first matches there. But the opening ceremony starts at 19:30 or soon thereafter. I think if there are not many questions, should be done by then. Our speaker today is well known to us because it's not the first time he presents within our Clinix webinar series. Dr. Mmusakgotla Modise. Dr. Modise is a diagnostic and interventional radiologist. He works with a team of radiologists, Mashau and Gisauza Incorporated. We rely on them a lot within Clinix Health Group and elsewhere for their expertise. He got his MBCH brief from UP, University of Pretoria, Steve Biko, but proceeded to do his master's in radiology from Sufago Makatu University of Health Sciences. He did his qualification in peripheral embolization in Turkey, in the Sakura City Hospital, and he's a well-known, as I said, interventional radiologist as well. Dr. Modise is keen on teaching, and he talks very well, and you'll see how he does. And I think he enjoys teaching, so we encourage you to ask questions at the end about what he's going to say about hemorrhoids today and the most modern way of managing them as well. Thank you very much. Over to you, Dr. Modise.
Thank you, Dr. Kinoshi. Thank you for the wonderful opportunity that Clinix is affording us as clinicians working in the health group. Just a small introduction. I'm a partner in Dr. Mashau and Zishawi Incorporated Radiology Practice. I joined the practice in 2017, so I've been around for a bit of time. We offer different services, a wide range of services that we offer, and like Dr. Kinoshi have already introduced, we are servicing most of the Clinix Health Group hospitals. At the moment, we're servicing 5 hospitals. Let's say Dr. S.K. Matseke Memorial being the main one that we actually centralized in, and we offer a variety of services. My topic today is called hemorrhoidal artery embolization. Before I continue, I just want to say thank you to my wife and kids for allowing me to sit in front of you and getting a time to actually prepare for this presentation. So what we're discussing today, I know when you walk around the corridors, the surgeons, they will ask you, Modise, what are you trying to solve with hemorrhoids? Because we've got variety of treatment options that we already offer. But the most important part that we always say to our colleagues is that this is an option of treating patients. It's a collaboration between us, interventional radiologists, different surgical disciplines, because I do different procedures. But today's topic is focused more on hemorrhoids, which is in the umbrella of surgeons and gastroenterologists. So it's a collaboration. It's not that we're trying to take patients away from the colleagues, and we're really not trying to solve the problem of hemorrhoids. We're just trying to give patients an option. So my focus is more on patient-centered, and with the patients winning and with the treating doctors winning as well, because the patients don't have to come to them many times for treatment. So just starting with a definition of why we're talking about hemorrhoids. Basically, just a basic anatomy description or definition of hemorrhoids. They are known as normal vascular formation present from birth in all individuals, and they are complex vascular structures made of both arteries and veins anastomosed together, which is defined in our medical literature as corpus cavernosum recti. Physiologically, the hemorrhoids are their main purpose and their main role in our bodies to actually preserve bowel continence. And they are made of this anastomosis are joined together to form what they call shunts. and the cluster of shunts create cushions. So anatomically, we have 3 cushions in the anorectal junction. So this is just a schematic diagram of what I'm talking about. So surgeons will be much aware that we've got what we call internal and external hemorrhoids. So our focus is mainly on internal hemorrhoids because we know anatomically that external hemorrhoids are basically venous. So there's no arterial feeders or that we require us to give attention to internal hemorrhoids. So our treatment is predominantly only on internal hemorrhoids. So you can see on the diagram there, we've got veins and arteries, which are depicted by the colors. And you can see those, the cluster where the arteries, the internal, where the pointer in the internal hemorrhoids there, you can actually appreciate that, sorry about that. You can appreciate that the actual diagram demonstrate they form like a bag of grapes there. So those are the arteriovenous anastomosis that I'm talking about. So pathophysiology of this hemorrhoidal disease is quite complex and poorly understood by all our health professionals. It's complex, multifactorial, but is generally defined as hypertrophy of this hemorrhoidal vascular plexus, which causes chronic symptoms, which mainly bleeding as a main symptom that we actually focus on trying to treat and help the surgeons to manage these patients. So with chronic hypertrophy of these hemorrhoids, then you will have resulting dense arterial and venous lakes, which will cause multiplication of the shunts that I've demonstrated on the schematic diagram. So with this multiplication of shunts will require increased flow of blood from the main supply, which is the superior rectal artery, which is our main focus point of treatment. So this corpus cavernosum rectum, it will act as a vascular malformation, not at clinical AVM, but when you do imaging, it will appear as AVM on imaging and will result in long congestive symptoms. Commonly, we know the patient might bleed, the patient might develop thrombosis, and the patient will develop what we call prolapse as well. So the reason for us to address this is that it's a very common disease. Most people are not aware, but it's very common that it affects 50% of the population. Hence, we try to offer an additional way of treating this condition. So 1 in 2 people will experience hemorrhoidal symptoms at least once in their lifetime. This results in major impact of quality of life, and it affects all age groups. So it will definitely have impact in professional activities of the patients. So the main symptoms, like I said initially, you'll have commonly the patient will present with bleeding, which is painless, and they'll notice after they sit in the bathroom that the kind of bleeding will present with bright red blood. Some patients over a period of time, they'll develop prolapse, which is also not painful, but this prolapse can thrombose. That's when the patient will feel severe pain. And when patients present with severe pain only with no history or symptoms of bleeding, we have to exclude other causes. We know anal fissure can present with active bleeding in the anorectal region. And we refer this patient, we ensure that the colorectal surgeons do rectoscopy to exclude, proctoscopy to exclude other anorectal pathologies that may present. So generally in surgical terms and also in other, all the medical classification of this condition is divided in, it was developed by Golika, and he has classified it into 4 groups, which we are be focusing on these grades as we go by. Grade 1 patient will present with no protrusion at all. So they'll have things like irritation in the anorectal region, they'll have bleeding. Grade 2, they'll have a significant extent of protrusion, but it's spontaneously reduced. The patient will describe this to very well in outpatient assessment. Grade 3 are those patients that when they are from the toilet, then the protruded part of the hemorrhoid will require manual reduction. So that is classified as grade 3. Grade 4s are the ones that present with protrusion with no success in attempt to reduce the prolapse hemorrhoid. So standard treatment, irrelevant of the grade of presentation, the surgeons or the treating doctors will advise patients on diet and hygiene. They'll try the over-the-counter medication like flavonoid drugs or topical anesthetic creams to alleviate the pain. There are other non-surgical options which are commonly done in the rooms of the treating surgeons. They can do elastic band ligation. They can use infrared coagulopathy as well to try and treat this patient with a minimal invasive procedure. The most standard surgical procedure that we're all aware of is called hemorrhoidectomy, which is actual manual removal, surgical removal of these hemorrhoids. So in terms of other options that where we come in, there's treatment called Doppler guided hemorrhoidal artery ligation. I'll demonstrate that later. And the option that interventional radiologists around the world are offering is hemorrhoidal artery embolization. So surgical treatment standard is called Milligan and Morgan. It was described by the surgeon more than centuries ago, which is classic removal or hemorrhoidectomy. There's another option they call, the surgeons are much aware of these options better than me, is called Longo procedure, which is stapled hemorrhoidopexy. And the other option, like I said, is Doppler guided ligation with or without mucoplexy. And the other minimal treatment option is using laser treatment or RF ablations. So this is just a schematic diagram just to orientate everyone. When you talk about Milligan-Morgan surgery, you can see that the surgeon will definitely remove the 3 cushions as depicted by the picture there, which is a standard procedure for grade 4. So this procedure is mainly preserved for the grade that is more severe, whereby other minimal options are not going to yield expected results. The disadvantage about this procedure is that the patient will feel severe pain in the first week as expected because it's an invasive surgical procedure, and the pain might last up to 6 weeks. And long-term issues with this procedure is that the patient will develop fecal incontinence, tenesmus, or even anal stenosis, which is rare as compared to the 2 long-term issues that I've demonstrated. Recurrence is on a lower scale, is between 6 and 14%, according to the literature. The second option, which is called Longo procedure, is preserved for advanced grade 3, grade 4, and it's less painful, so it's one of the good options. Patients are expected time of recovery is shorter, but the issue with this procedure is the rate of recurrence, which is up to 32%. And these patients, majority of patients report high incidence of tenesmus post-procedure. My favorite one is this Doppler guided hemorrhoidal artery ligation. The reason why I'm saying that is because Prof. Vidal in France in 2014, he used the same. This is a concept that actually guided him to start exploring embolization of the hemorrhoidal artery. So you can see on the diagram there is a Doppler ultrasound inserted in the anorectal region, and with the guidance of Doppler, because on Doppler the arteries will show a red color, then the surgeon will use the same probe to actually ligate the arteries. And you can see on the far right picture there's an artery coming down and the switcher going around to actually ligate the artery. So this is the procedure that actually gave birth to what we're doing, and it just shows that we don't disregard the surgeons, but we develop our idea of doing this procedure based on their initial technique. So the procedure is painless. Minor complication, patient can develop tenesmus post-procedure. They can develop minor pain, and urinary retention is reported as one of the complications. The issue with DGHAL is that the rate of recurrence is quite high as well, which is up to 30%. So if the most important thing is that we need to do a lot of randomized trial to compare the actual procedure, because they are more of a similar kind of approach. Most of this, the reason why I'm highlighting this slide is I was just comparing in terms of the actual techniques between the 2 procedures, because with HAE, the advantage is that we can identify all the branches, whereas with Doppler, you are limited because you cannot actually pick up all the arterial branches that we want to treat. And with anatomical variation, then the extent of success is quite reduced as well. So effective occlusion of targeted branch is more with HAE as compared to DGHL. And with hemorrhoidal artery embolization, we do get more improvement in results as compared to the surgical option. So coming to the procedure of interest that we're discussing today, I'm putting a disclaimer again, it's not a radiologist going to the street and getting patients. This is a multidisciplinary team approach involving interventional radiology and treating surgeons. And all these patients are referred by the surgeons to us as a treatment options. And with collaboration with the surgeons, they will discuss these patients before to see if this option will be suitable for these patients. The follow-ups are done by me and the referring doctor, whoever is suitable to, who's willing to follow up this patient. So in terms of workup, first point, clinical history is important, which we'll get from the surgeon, and as well as myself, I do pre-consultation for this patient. We do basic bloods to see if the patient is not anemic, patient doesn't have any underlying medical condition. All the patients, preferably, they should have colonoscopic exam to make sure that we don't deal with any other anorectal pathologies instead of hemorrhoids. So the bleeding score, which is a chart that I'll demonstrate on the next slide, it's important for us to have that chart because it will help us to follow up to see if there's improvement with bleeding or not. Like I demonstrated Goliath classification, that's our guidance in terms of treatment approach. So this is just a table to look at the variables that we point out when we work up this patient. So the most important part is that the frequency of how often these patients experience bleeding, what type of bleeding, because there's a difference between seeing blood in the toilet bowl or just after activities, then the patient wipe and notice blood in the tissue or in the towel in the toilet. So the important other history is the anemia. If they've been treated for iron deficiency anemia before, they've been transfused or without transfusion. So the higher the score, the higher indication for considering treatment. So this is an approach that we use to actually select patients. So based on what I've already mentioned, the history, the blood workup, with clinical examination from the referring surgeon, colonoscopy, and digital rectal examinations. Post that, we classify the patient whether they've got grade 1, 2, or 3, or grade 4. Generally, we know grade 4 is basically reserved or preserved for patients that will undergo surgery. If there are any surgical contraindication, we can still assist this patient with embolization. But from the experience and from the literature, we know that embolization with grade 4 patients will not obviously take away the prolapse hemorrhoids, but it will just reduce and help with the symptoms of the patient. So if there are any contraindications to surgery, then we can really consider embolization. So with grade 1, 2, 3, we do bleeding score, we do quality of life assessment. And with patients that have underlying cardiovascular disease, it's important to do CT pelvic angiogram. I'll show you a diagram later, which actually identify with variations of patients with atherosclerosis, which will actually assist which kind of access the interventional radiologist will opt for. Advantages of HAE. I know we're operating in a private setting. Short hospital stay is not recommended because our health groups won't be happy with us. But in general, it's a very short hospital stay procedure, which doesn't require a patient to stay overnight in the hospital. There's no special diet required for this procedure. There's no pain associated with this procedure, which is one of the main highlighted advantages of doing this procedure. There's significant reduction. We do not say and we do not promise the patients that they won't experience bleeding post-procedure, but there will be significant reduction. The prolapse is reduced in size, obviously, because we have reduced the flow in the superior rectal artery. Success rate is very high based on the literature. I'll show the statistics, the numbers later. 80% of these patients are satisfied on 3 months follow-up. 20% may require re-embolization. If patients not suitable for re-embolization, we will refer these patients for surgery. One of the advantages of this procedure is that the anal continence is preserved. Remember, that's the whole purpose that the patient will want to maintain, which when we look at surgical procedures, there is an associated disadvantage when it comes to continence. Patient that undergo HAE, hemorrhoidal tissue remain intact. So we're not cutting anything, we're not stapling anything. Hemorrhoidal tissue and physiological function of the hemorrhoidal tissue will remain. Just to orientate everyone, this is what we call global angiogram of the superior rectal arteries, that our main focal interested vessels that we embolize when we do this procedure. So the black arrow there shows, so the main big vessel that you see in the middle is inferior mesenteric artery, which we cannulate from the abdominal aorta. And you can see the lower branches there that depicted by the white arrow there at the bottom is basically the superior rectal arteries. So the one that is depicted by the white arrow at the top is the left colonic artery, and the black arrow is the sigmoid artery branch. So our focus is mainly on those lower branches, and we know naturally that the superior rectal artery have 4 branches, which is both 2 anteriors and 2 posteriors. So just an anatomical orientation on the slide. And for us, for people who are non-medical in this platform, this is just a diagram that demonstrates what I'm talking about. So for interventional radiologists, we know that with hemorrhoidal disease, you can have different presentations. And when we do the angiogram, we look for the prominent or hypertrophic vessels. So if you see in those diagrams, you can see the top diagram there, the vessels that are more reddish in color, those are the hypertrophic or dilated vessels. So with the type 1, we know that it's only the superior rectal artery branches that are actually affected, and type 2, because anatomically we know that the hemorrhoids are also supplied by middle rectal artery. So when you do an angiogram, it's important to identify which ones are dilated or hypertrophic, and we treat those. So there are 3 types of possibilities, whereby type 1 will give you both or 4 of the superior rectal arteries that are hypertrophic. Type 2, you will see unilateral either in the left or the right. If you see the hypertrophic left, most of the time, the contralateral middle rectal will be the one that is hypertrophic, as demonstrated by the second diagram. The third diagram, which is rare, is around 10% of patients. You will notice that the hemorrhoids are only supplied by middle rectal artery, which is depicted by those reddish vessels at the bottom. Going back to what I'm more familiar with, which is digital subtraction images, you can see on the left side there, you've got both dominant superior rectals, which are dilated, and the posterior rectals are reduced in size. The image on the right demonstrates 3 prominent, which is the both anterior left and right, and a posterior left, which are demonstrated by the arrowheads. So this is a type 2, whereby you will see that when you do global angiogram, you see the white arrow showing a hypertrophic right, and the left is small on the demonstrated by the yellow arrow. And when you do an angiogram, you'll see that there's reflux into the left middle rectal artery, which is demonstrated by the black arrow. So what we do is we embolize the vessels demonstrated by a white arrow, and we go back to the iliac vessels and cannulate the middle rectal artery from the internal iliac artery branches. This is the last option that I showed on the schematic diagram, whereby only the middle rectals are the ones that are supplying the hemorrhoidal tissue. You can see with the white arrow, when you do, so initially, obviously, we'll start with inferior mesenteric. You can see a catheter coming from the top there. And we can appreciate that the middle rectal arteries are quite small, but there's reflux. The superior rectals are small, but there's reflux on the left middle, shown by the white arrow. So you target and embolize that. And also on the contralateral side, on the right side, you can see when you do an angiogram in the superior rectal artery branches, which are quite small, you'll see the reflux again going into the right middle artery, shown by the black arrow, which will target and embolize. So this is just a summary of what I was just demonstrating there, that sometimes when you do global angiogram, you'll see a prominent middle rectal artery, or when one side of the superior rectal is enlarged, then you have to look for the middle rectal, because anatomically middle rectal will be the one supplying on the contralateral side. At sometimes you need to go distally on the superior rectal branches to open up the middle rectal anastomosis, so that we can identify the feeders of the hemorrhoidal tissue. Like I demonstrated on the diagram, that CT angiogram is sometimes recommended. We don't routinely do CT angiogram of the pelvis. It's necessary with patients that have cardiovascular disease or high risk of atherosclerosis to identify anatomical variation, help with procedure planning, reduce procedure time, which is important in radiology, and reduce risk of failure or requirements for re-embolization. So this is just a diagram to show a post-processed image, CT on the right side. So this is the image that you'll get when you do CT angiogram, which is similar to the DSA image on the right. So it will assist with identifying the branches from the inferior mesenteric and going down to the superior rectal arteries. Step-by-step approach of this procedure, there are different access methods that we can do. My go-for method is radial access because of various reasons. I rarely do femoral access, but there are many. This is based or dependent on the experience and the preference of the interventional radiologist. The advantages of radial: patients can literally go home 2 hours post-procedure, as compared to femoral access, which will require hemostasis and monitoring of the puncturing site. With radial access, we use what we call a radial sheath. It's a 5 inches, quite small, because radial arteries are around 2 to 3 millimeters in diameter. We use what we call radial cocktail to preserve the patency of the radial artery and to prevent spasms. So we do a combination of those drugs listed. We use nitro, we use verapamil and heparin to add up to create a cocktail that we require. We use long catheters, 125 centimeters, preferably the hockey stick type shape tip. I usually use Benston. If Benston is not on the cupboard, you can use Headhunter as an option. And once cannulation of the inferior mesenteric artery, we do a global angiogram, which I've demonstrated on previous images. We connect the catheter to a pump and give a small volume of contrast to open up the vessel, so that we can identify the variants that I've demonstrated on the previous slides. With radial access, you're required to use long microcatheter. You can use 150 or 175, which will enable us to get to a point of the superior rectal arteries. Femoral access is a well-known common access done by interventional radiologists for variety of procedures. We use 6 French sheath. No cocktail is required because the vessel is bigger, it's not prone to spasm. For inferior mesenteric access, you need to use a reverse catheter because of the anatomical position and exiting angle of the INA from the abdominal aorta. So we use SIM or Cobra catheter, which will assist or enhance cannulation of the inferior mesenteric artery. With femoral access, you don't need to use hydrophilic wire. You can use a standard wire because there's no risk of vascular injury based on the size of the lumen of the femoral artery. With femoral access, you don't really require a long microcatheter. You can use a short microcatheter and microwire. Embolic materials, there's a lot of research being done by interventional radiologists in terms of the usage, different options of embolic materials that we use. Coils have been well studied, well used before by the founders of this procedure. And coils have shown effectiveness with minimal issues as compared to other embolic materials. I'll show later on the presentation, there's a study that was done by a group in Egypt, which they only use particles. The group in Europe, in the UK, they use a combination of particles and coils, which has an advantage as compared to just using coil. There's a group in France that have been exploring embolics glue. We call it magic glue, which actually works as well, but there was a skepticism because of the issue of necrosis related with glue, but there are papers that have been published that have shown the safety of using of liquid embolics for this procedure. Like I've said, coils are well thoroughly studied, and with good numbers and evidence that there are no issues associated with coils. We use small size coils, 2 to 3 millimeters in diameter, with a length of 4 to 3 millimeters. There are options of using pushables, which are quite cheap and easy to use. The detachable coils are much more nicer for us to use, but expensive for the patients. So you have to look at your surrounding and accessibility of these coils. There are options of using a fibered coil or hydrophilic one, preferably fibered coil, because fibered coils will result in getting early thrombosis of the superior rectal artery. So we prefer fibered coils because of better results from using the fibered coils. Like I mentioned, coils give proximal embolization. So the target is to embolize as close as possible to CCR or corpus cavernosum recti. But with coils, you cannot go further beyond the pubic symphysis. So they give you proximal embolization, but they are safer as compared to other embolic materials. So particles, they initially, because with fibroids, we use 500 to 900, which are smaller coils. So with hemorrhoidal embolization, there is a preference of using bigger particles to minimize ischemic changes in the anorectal region. So 7 to 900 micrometer diameter particles have shown to work much better as compared to smaller particles. So per vessels, we use small volumes. Prof. Vidal in Paris actually said that for him to be sure of what he's doing, he doesn't actually measure the volume of particles that he uses. He actually count them one by one, using up to 25, which will definitely require a lot of time to sit down and count the particles from the vial. But we know that the smaller particles have associated issues. Patients will present with procedure pain, tenesmus, or post-embolic syndrome. So throughout years, interventional radiologists have moved away from using small particles for this procedure, rather go for bigger particles, which are more safer. There's one case that was reported in the US. We're not shy away to comment about our complications, guys, as compared to surgeons. No one knows with their complications. They do what they call relook. So for us, we're not shy to talk about complications. So there was a case that was reported in the US, but with investigations, it was a case that the IR used smaller particles. So the patient post-procedure, after a period of time, they developed stenosis, anorectal stenosis secondary to ischemia. So as compared to coils, particles have an advantage of distal embolization. Hence, the UK group used a combination of the two, which have shown better results. I'll demonstrate that on the later slides. Liquid embolics, still on assessment. There's still a lot of research in terms of using liquid embolics for HAE. But the recommended dilution, because we dilute this with contrast so that we get good filling of a vessel and stasis. The recommended ratio is diluting 1:5. It's a new option with a lot of research, but with the earlier data, it has demonstrated high risk of ischemia, which is a concern when it comes to liquid embolics. Few cases, I'm just going to demonstrate two cases. One patient, 60 years old. Like I said, we have to get a bleeding score for this patient. We have to grade them because we want to treat a specific grade, because we know that grade 1 to grade 3, we get good results with HAE as compared to grade 4. So this is a patient that presented with bleeding score of 7. You can see on the angiogram on diagram A, you can see that the anterior superior rectal arteries are hypertrophic or dilated, or they look bigger than the other vessels. So we definitely go with a microcatheter, put those small size coils that I've mentioned, close it up and go to the other side, do another run and close. So you can see there are multiple coils there. So the main is to achieve what we call near stasis in interventional radiology, basically meaning that when you do your post-procedure run or angiogram, you don't see contrast passing the point of embolization. Case 2 is a female patient as well, grade 2, bleeding score higher, with different presentation. So on initial angiogram, you can see that only the right superior rectal artery is prominent, the left is small, but there's reflux on the middle rectal. So embolize the right, put few coils on the left, proximally there because it's a bit hypertrophic, and reposition, go to the branches. You can see that the diagram on the right there is demonstrating the selection of the iliac artery. Usually the middle rectal artery comes from the obturator artery, so you can see obturator artery going down there. So you select the MRA and embolize as well. So comparison was done by Trivy in UK, whereby 2 groups of patients were looked at. The ones that have only undergone superior rectal artery embolization and the ones that have experienced both SRA and middle rectal artery embolization. You can see that on follow-up, patients that had the combination of the both groups of vessels have a better bleeding score as compared to only superior rectal artery embolization. And the most important point is the rate of reintervention. The ones that were only embolized on superior rectal needed to be re-embolized at 42%, whereas if you do the combination of superior rectal and middle rectal, you get a good result in terms of requirements for a reintervention. The most important part, which my surgical colleagues don't believe, is that we don't have complications associated with this procedure, but that's a reality. Follow-up, we commonly do 3 months follow-up, either by interventional radiologist or by surgeon, repeat bloods to see if there's improvement in HB levels, do a bleeding score again to see if there's improvement of score, quality of life score as well, to see how the patient, there's a long questionnaire of quality of score, and we reclassify again to see if the grading have downgraded. Complications that commonly associated with interventional procedure, commonly we get a puncture site complications, especially with the femoral. That's why I'm not a big fan of femoral. You can get hematomas, pseudoaneurysm. Commonly with radial access, you can get spasms, which we minimize by using a radial cocktail that I elaborated on initially. Patients can experience post-embolization syndrome, which is only associated with the usage of particles. And most importantly, the small size particle, the big size particles, patients will have minor pain and a bit of tenesmus, but with cause, there are no issues associated with post-embolization syndrome. Few patients can develop pelvic infection post-procedure, which is rare. Like I mentioned already, there's only 1 reported case of rectal ischemia with all the research and the data that has been published over a period of time. So one data that I want to highlight to everyone, because people will always believe that we present things that are just new on the market. This procedure was started in 2014. There are a lot of studies that have been published. There was a meta-analysis study that was published in 2022, which combined studies from 3 different centers, which enrolled 381 patients, which is a significant number in terms of statistics. And on follow-up, patients reported, 82% of patients reported significant reduction in bleeding, and 95% with follow-up imaging, the 95% of patients complete occlusion of these vessels was demonstrated. 87% of patients were satisfied on assessment of quality of life scoring, and no reported complications. I just want to point to this study, which is an African study. It was done by Prof. Karim in Egypt, which he actually did a retrospective study using particles only. So I just want to make a point that the usage of particles is well recognized. He enrolled 33 patients using particles of size 7 to 900. And with those patients, there was significant satisfaction in terms of follow-up of these patients. He selected grade 2 and grade 3 patients, grade 3 grading hemorrhoids patients, and follow-up patients. There were no issues, no complications, no report of ischemia. All the patients were satisfied on 3 months follow-up. So particles do work, but there's more data, there's more information when it comes to coils as an option for treatment of hemorrhoids. My endpoint comment is that we want to achieve complete occlusion of targeted vessels as compared to Doppler-guided hemorrhoidal artery ligation, like I've compared the advantages of HAE as compared to that treatment option. So the goal is not to replace any surgical therapy, but rather to offer additional option to treating of patients. I thank you. Here's my references. Thank you.
Thank you very much, Dr. Modise. You can see the applauses on the screen that reflect, I think, the gratitude that our audience has after listening to your amazing lecture. I think it's something that many of us as doctors did not learn at medical school when we were there. And we hope that with time, the syllabus encompasses a new methodologies in treating clinical illnesses as and conditions as you have described. Thank you very much, Dr. Modise. You mentioned several times that surgeons might not be appreciative of these new methods. I'm just wondering, shouldn't there be more cooperation actually between clinicians and interventional radiologists and working together and actually booking cases together, if possible, instead of any rivalry that may happen between the two clinical disciplines? What's your comment? If there are any surgeons in the room, they can come in on this one.
Yes, Dr. Kenoshi, just to comment before we get questions from everyone. Interventional radiology is quite an exciting discipline for me personally because it actually plays a central role in management of patients because we offer a variety of options on treating different conditions, but with a minimal invasive approach. I think the main purpose here is a minimal invasive approach, but like I mentioned on my first slide, everything is collaboration between us and the surgeons or us and the gynecologist or us and the orthopedic surgeons. Interventional radiology is closing the gap of offering treatment options. I think that's the main message that we're trying to put across. But I mean, if you look at the medical environment as a profession, you'll find that especially in private practice, everything is sort of revenue driven rather than patient centers. And I think that's the gap that we need to bridge, because it will allow us to give patients good options in terms of treatment, put all the options in the table so that patients can choose for themselves. And those ones that are surgically contraindicated, use the option of using interventional radiology. That is why I always say to my colleagues that this is not a competition, but this is patient-centered approach. And we're not saying that we don't get complications. We do get complications, but with minimal invasive procedures, complications are minimal, like the procedure is minimally invasive, but complications are there. Yeah.
That's right. No, that's fine. I think our first oral question is from Professor Dirk Du Plessis. Professor Du Plessis, you can unmute yourself, please. And I see you put something in the chat box as well, but maybe you can unmute yourself and go ahead, Prof.
Unmuted. Well, thanks a lot for that. It's a very important topic, I think, for most people on the planet. Now, as far as there's no, I think, fight between surgeons and interventional radiology. It is literally, I think, currently, as we said, a very common thing. Yes, in cardiothoracic surgery, we also use it. With our colleagues. In other words, they do us a great favor on many occasions with the intervention that they do. It makes some things a lot easier. My questions that I just asked is, or let's say almost a caution, I can maybe just mention it here. The embolization of an artery is always the risk of distal necrosis. Especially if a problem happens, it might be that, oopsie, maybe I just embolized a little bit too much, or maybe the wrong one. and it is irreversible. That is the issue. And the whole point of embolization is actually, you're going to cause distal necrosis, but if it's little enough, then the body can take care of it. It'll clear up the mess that's now created distal to the embolization. But if it's a little bit too much, then it's got trouble trying to clear it up. The second aspect is that um, in your hemorrhoidal area, um, that's also a lot of other connections that take place there, especially between the splanchnic circulation and your systemic venous circulation, which is now obviously something you see. Someone's got liver failure or to some or the other degree, then you see this night kaput Modise on the abdomen, and you also see exactly the same thing in the anal area, because that's where the connections take place. So I suppose there are some systemic contraindications that must be very, very prominent in the mind of the interventional radiologist. It's not a matter of just quickly run over a couple of things and let go for it. Because in that way, you might end up with a lot more trouble than you bargained on. But it's an interesting thing that I didn't know existed. Thanks.
Thank you. You can go ahead,
Thanks, Prof.
Prof. You can go ahead.
That's fine. That was my
Okay.
just my
Yeah.
input. Yeah.
Okay. Thank you very much, Professor Du Plessis. Any comments on Prof's comments and questions, Dr. Modise?
Dr. Kenoshi, I understand Prof's concern when it comes to the embolic materials that we use, but we do a lot of research and we do a lot of data analysis on the actual. That is why I made it a point that I mentioned 3 different embolic materials that we use, and we know physiologically the consequences of using each of all those embolic materials, and that is why I summarize by saying that there's a lot of data that we collect when we follow up these patients. And I know when I attended a conference in France, there was a surgeon who actually presented what Prof just said, that with using of coils, you will find that if you want to do a surgical procedure later, if you do a rectal exam, you can actually feel the coils with your finger. And when you use what do they call this bending instrument that they use, then you can actually create an electric shock when you try to do hemorrhoidectomy on the patient that has done coils. So we know that there are issues. Sorry?
Is that cauterization you mean?
Yes, I wanted to say cauterization. So you'll find that the coil interact with the cauterization machine. So it's important even for patients to be aware that with my hemorrhoids, I've used coils so that when they go for surgical intervention, then they are aware that the coils are still in place. So we're much aware of what Prof has raised there in terms of the consequences of using all the embolic materials, but we know how much you need to use. For example, fibroids, we know that the end game is to achieve near stasis, and that's what we want. And obviously, if you inject more, then you'll cause problems than solving problems. And the other issue is you will get non-targeted as well. So I think for GIT work, the most important thing is to use what is required and what has proven to the amount of embolics to achieve a goal, not to cause harm.
Okay, thank you very much. I see we've got Dr. Bongani Shabangu. Dr. Shabangu, please go ahead.
Good evening, colleagues.
Great.
Good evening,
Doc. You can go ahead.
Thanks, Dr. Modise, for the wonderful presentation. My question regards the cost comparison between, especially for grade 3, I'll say grade 3, grade 2, grade 3, in terms of either the embolization versus the hemorrhoidectomy. How do they compare? That's the first one. That's a question. And then my comment is on the reason for the low uptake for this option. Mainly is limited by the medical aids that our patients are using. side of town. Maybe there is more that needs to be done with regards to the medical aids. Maybe someone needs to educate these medical aids about the evidence-based benefit of option versus what they usually. Thank you.
Okay. Okay. Thank you, Dr. Shabango. Dr. Modise, go ahead if you can answer any of those questions, please.
Yes, I'll answer both of
Or
them.
both.
Yeah, so obviously in terms of cost, Dr. Shabango, using interventional procedures, they are quite pricey as compared to any surgical intervention. I mean, even if you look at the basic thing like fibroids, it's much more expensive to do UAE as compared to myomectomy. So in terms of cost, interventional procedures are quite higher costly. I mean, one coil, I can tell you the price, but this is a public platform, you know. So they quite pricey, Doc, when it comes, if you compare the two options. But for me, the most important thing, everything has to be patient-centered. If the patient will benefit, you know, then go for a more beneficial option for the patient. And then in terms of, you are quite correct, in terms of the community that we serve, the medical aid are quite an issue to actually get authorizations for these procedures. You know, it's a tall order when it comes to medical aid. Most of the time, they'll tell you the options are the issue. Because with patients that are high-end options with this medical aid, then they tend to be funded for these interventional radiology procedures. You know, so just to make an example, I mean, I do ECOS procedures for PAE, but you will find that with these low options, I mean, it's quite an urgent procedure or PNB or what we call it. You'll find that the medical aid, so no, we don't cover that patient. And patients complicate and demise in ICU without no intervention because of the medical aid option, you know. So I don't know what can be done by that, but that's the common problem that we experience with the medical aid options in our community.
Yeah. What contributes to it being more costly than surgical procedures, Dr. Modise? I mean, I think one of the advantages you stressed was the fact that short stay in hospital and risk of complications are much less. A risk of losing anal continence is much less if not reduced to zero. So medical cost to medical aid should be much less. So why would they be more costly? Is it what you use to?
Yes, the driver of course, Dr. Kinoshi, is the consumables because all these materials that we use are exported. They are not locally. You know, the embolics are from companies like Merit Boston, which are, you know, American companies, the coils as well. So it's the consumables that's driving the cost of the actual procedure more than the actual cost under the hospital.
Okay, no, that's fine. I think we've got, thank you, Dr. Shabango, for your questions. We've got a question from Dr. Silla Maloka, who says, can you comment on anastomosis and revascularization? I suppose if you want to reverse the procedure. I don't know why he's asking that question. You can unmute and explain further if you'd like him to do that, Dr. Modise.
Yeah, the question is quite not clear. Can he elaborate more?
Yeah, I was trying to understand it as well, because if you need to anastomose and revascularize, it means you probably want to reverse your procedure.
That's creating hemorrhoids again.
Exactly. Dr. Maloka, Silla Maloka, can you unmute yourself and explain your question or comment? You can go ahead and do that. Dr. Maloka is not unmuting to explain. I don't see any other questions unless if you can see them on your side. Dr. Modise, I don't see any other questions or comments, but
Okay.
yeah. That's right. So I would like to, I think, oh yeah, there's a question from Dr. Bongani Mbata. There's a hand from Dr. Bongani Mbata. You can unmute yourself, Doc, and ask your question or your comment. Dr. Mbata, you've been allowed to unmute. Just unmute yourself. Click on the microphone that has got a slash across it. It will open. Can you? Okay, there it goes. You can go ahead and now it mutes again. Tolakela, can you ask this, Dr. Mbata?
Dr. Mbata, please unmute yourself.
All right. Otherwise, you can put your question in the chat box if you can unmute yourself on your side. Any questions that remain that after we've closed will be sent to Dr. Modise for him to respond to you if we've got your email address. Dr. Mbata, I think just one more a chance, please. Looks like we are failing. Sorry about that, Dr. Mbata, but I think on your side, we've unmuted you. You are not restricted to unmute yourself. But I think let me close by thanking everyone who participated today. I mean, we had well over 400 attendees today. And on a day that people are anxious to see Bafana. The game is only starting later at 9:30. I've got my vuvuzela ready for all those who would be joining me. Later this evening, we're hoping for a win, Dr. Modise.
Yes, we're wishing them all the best, Dr. Kinoshi.
Yeah, I predict a 3-1 score in the favor of Bafana.
If we can just draw this one, we just need to draw this one, Doc.
Okay, yeah, but the win would be even more welcome to next reporters. Thank you very much. But I think, Dr. Modise, we really appreciate the effort that you take in preparing your very detailed presentations. I think they give information, even technical information that I think all practitioners would like to hear, and convincing arguments why you think this method of treating hemorrhoids can be beneficial in the end for the patient. We hope that the cost will decrease with time and with utilization, and with maybe getting the consumables locally or cheaper. I think we need to market ourselves on this more with the medical aid schemes themselves, because they do a lot of managed healthcare. So we can talk to the doctors in the medical schemes themselves about procedures such as this one. And I think it's not the first time you do a presentation on Clinix webinar, for which we are very thankful. We also urge those amongst the audience who would like to offer themselves to talk to colleagues and on any matter that they have expertise on, that they are working in any topic of your choice. I think you're welcome to offer yourself. Just contact us on webinars@clinix.co.za, webinars@clinix.co.za. You may also suggest your colleagues who would like to offer talks in future. We have a webinar next week, Thursday, also. It's from one of the South African Society of Clinician Scientists. And I think we will send a notification within the next few days so that you have an opportunity to register yourself and get a Zoom link for the next webinar. Those who've been attendees before, you've given us your email address. We do send notifications to all of you as well. So check in your emails, although we also put webinar invitations on almost all doctor groups that we have access to, WhatsApp groups and so on. And I think, but you are allowed to share the invitations, but we do advise everyone who would like to join the webinar to register himself or herself rather than get a second-hand Zoom link. I think Dr. Modise and the team behind, Tolakele, Neo, Sister Nesisa, thank you very much. And thank you very much to all the attendees, the regulars and the new ones. You'll be welcome to join us again next week and every Thursday thereafter. Good night to you.